Hello. Okay. Hi. I'm a pediatric ambulatory lead for Morecambe Bay. And I've been there for 3.5 years. And things have changed quite a lot. Things have evolved. So I'm going to talk about things. A lot of it is similar to what you've seen and things we're doing. And it's not a very long presentation. There will be more discussions around things. Okay. So, integrated pediatrics has been discussed. This is the age of integrated pediatrics, which is what you were talking about in those previously. It's fluid, it's not rigid. If you talk about integrated pediatrics, you sort of stop all the boundaries. You're coming in, you're working around the child. There are resources like Imperial was mentioned, London was mentioned, Royal College, Pediatrics Child Health. Connecting Care for Children is something that came out of London. The King's Fund has resources, that's all. This is all put in a slide, and this is your middle bit is the Integrated Child Health team. So that's sort of, and it's all, for us it has been around the Better Care Together, which is one of the Vanguard schemes. We got a Vanguard schemes by NHS England, this is for our area. And they have helped with this for 5 years. A lot of the funding has come from them. This is another slide, similar thing. Last slide you could see integrated health team, but that's not really it. We call our child SAM, so it's everything is around SAM. And this is the MDT approach which we have formed as well. So the focus is SAM, our child, and it's about getting rid of boundaries, any bottlenecks, red tape, anything. It's a fast, seamless service all around the child. Just going through our geography. Can't see that very well, but you got we got 3 hospitals: Royal Lancaster Infirmary, where I'm based, Furness General Hospital. You should have told me, you couldn't hear me. Okay, Furness General Hospital, Royal Lancaster Infirmary, and Westmoreland General Hospital. 2 inpatient pediatric sites, Lancaster Infirmary and Furness General Hospital. They're 50 miles apart. So it's a bit, that has to be kept in mind. Whenever there's any commissioning, anything needs planning, the hospitals are 50 miles apart. So that's a bit about geography. Then if I'm talking about geography, let's talk about ICCs as well. We are now into the integrated communities where GP surgeries have gotten together. We've got 11 of them, and we are trying to link in with all GP surgeries. Okay. So when I started 3.5 years ago, I started work at the hospital. A GP could phone the children's assessment unit and talk to a nurse and refer a patient, and the patient will come. So we thought, let's change this a bit. We've got a pathway, a referral pathway on, where you got either from emergency department, GP, community nursing, anywhere, you make a referral. But referral has to be a phone call to the senior doctor who can decide where this referral goes. At the same time, we started a rapid access clinic. So then the pathway goes down. Now, this is old, so this not nurses now, it's coming to the consultant or the medical grade. Different times we have consultants covering in the evenings. So you either go to rapid access clinic, come to the assessment unit, or inpatient, or you can refer on to the integrated children's nursing team. Further on, then these are the timelines where you can see, assess, review, and discharge or admit, etc. So this pathway came in, we are talking about 2015. So then we started doing some audits to look at our services, how we can change things. Sorry. Call from Wales. There's a call from Wales, I don't know. Okay, so what we did here is when we started this pathway 2015, we gave the person, the bleep holder, a logbook. For 2 weeks, they kept a log of all the referrals that came in. 10 to 15% of them were inappropriate or they could be redirected elsewhere. So this was an ongoing log, so this is a long time ago. So then this pathway came into place and people got used to it and things got better, the referrers knew them, etc. So we did another audit in 2017. This is a big one. So now this is a retrospective one. We re-looked at what had happened with these patient journeys. They had come 120 patients in total. Out of them, still 5% were redirectable, we felt. Now, what is redirectable is different if you're talking to a consultant or you're talking to a middle grade or talking to a trainee who's just come on or talking to somebody who's known the service for a while. So 5% we felt were still redirectable. And this is a flow of where did they go? 75% came to the Children's Assessment Unit. 15% advice was given how to manage, and 5% ended up on the rapid access clinic. So you can already see that with a proper pathway, how we are redistributing our patient flow. Needless to say, a patient needs to stay outside hospital, and that's where the current NHS is working towards. Okay, so rapid access clinic was also started at around that time. Now we have one slot in clinic every day. And I've got some, these are the rules. Some rules for what we're doing. So it's only new patients, new problems. People, it's just redirecting flow away from the Children's Assessment Unit where we're feeling this child does not need to be seen right now. I mean, they can wait till tomorrow or the day after. And we redirect the GP. They're usually seen within the next 3 working days. If they can't wait, there can be a discussion again and we can see them on assessment unit. And there are some examples of patients which have been redirected to the rapid access clinic. Now, one rule is there has to be a phone discussion. To have rapid access clinic needs to be a phone discussion so we know what's coming, and we also ask them to put the name of the consultant they spoke to in the letter or the email. And it doesn't need to be GP, it can be health visitor, it can be emergency department. Next is advice and guidance, which we was started in 2014. This is email correspondence with GPs. As you can see, it has grown. Initially, it was pioneered by one of my colleagues. He was the only one doing it. Then, sometimes he was busy, so he replied in a week, 10 days. Then we put it in the rota. We have allocated, it's in our job plans, and we share it. We share it week by week. So it comes in your regular email and you just answer it, and you know it's your week. Currently, it's around 2 per week, 2 per day emails. But we've seen that as people GPs know about this, this has increased. The activity, you can see it's increased. And roughly 50% end up in children's outpatients anyway. Okay, so if you look at that, now this is our business manager has told us, he's looked at the figure, he said roughly 50% end up in outpatients. So you can see you're kind of reducing outpatient referrals here. Okay, other new things that have come on is choose and book and patient-initiated follow-up. So the choose and book slots, they get booked, and we as consultants look at them and see whether they're appropriate or not. So 5% of them we can bounce. We don't think it's appropriate, we give them and we email them back with the rights, do this, doesn't need to be seen in clinic. So it's a bit like advice and guidance, but more formal, and as it's a formal thing, choose and book has been tried in other specialties, in other hospitals, parts of the country. It made its way into pediatrics, and first there was reluctance regarding this, but I think that is giving you, is avoiding attendances. The other is patient-initiated follow-up. There are patients where we feel we don't need to see, or maybe we need to see, not sure, discuss with parents, and we come to a formal agreement that, okay, fine, if you feel symptoms are not improving, etc., symptoms are improving, then you can, don't avail of the appointment. In 6 months, this service will run out. Again, 5% with this, we've reduced attendances. Previously, it was, okay, come back in 6 months and we'll have a look, and if things are okay, then bye-bye. But no, this has also reduced our attendances. These have started about, I think it's been a year now. Okay, MDTs. Right, so MDTs, like you discussed from Rosendale. It's been, I'm part of a trio. I'm the only one left. The duo with me couldn't make it today, who were part of the MDT, so I'm it. So these MDTs, going on for about 18 months. They are, I said we have 11 ICCs. If you sort this out. So we have 11 ICCs. Not everybody is keen on MDTs. We've managed to do them with 2 of our ICCs, the busiest ones. And in the MDT, so these figures I'm showing you are old. These graphs I'm showing you are old graphs. I'll tell you the numbers, the real numbers, which I've been emailed last night. Basically, this reflects what they've showed in the Imperial study in London, that your patient hospital attendances go down when you start doing MDTs. And how MDTs happen is you first identify. This started out as a frequent attenders project. So we've identified patients who are frequent attenders. You arrange MDTs in GP surgeries, or ICCs as they call them, where there's a community nurse, there's a pediatrician, there's a GP, and there might be health visitor, physiotherapist, and whoever else is there. You think is linked, like safeguarding was mentioned. They also started calling it Empowering Families Project, where the community nurses go to these children and they ask the parents, how would you like this service to run? What would you like for your child, and how do you want to, what are your obstacles, what are your problems, etc., etc. So the graphs that they were initial parts of the assessment. They've done, they collected data. They showed that their attendances had dropped markedly. So from the busiest ICC on our patch, 12 months data, 56 children have been in these MDTs, 5% reduction in primary care appointments after intervention, 41% reduction in inpatient attendances. And A&E attendances before intervention were 131 and post-intervention 48. So all the numbers go down except for outpatient appointments. They increase from 175 to 201. So there's a bit of increase in outpatient attendances. And the calculation done by the GP lead for this in the ICC, she says, over a 12-month period, MDTs saved secondary care a total of 70,460 pounds. This is brilliant and doesn't account for the quality outcomes. This is not taking into account, I think these finances are not balanced yet by your the pediatrician going out and the money for the nurse. Have I really broken this totally? Okay, so that's... And they've studied this in London, and they have a full service website linking. One of the link areas is Preston. Okay, so while they're doing this, you get it up and I'll talk about it. So the other thing, I think the most, my baby has been outreach clinics. So when I started, one of the things, so if you look at the King's Trust, there's different ways of working integratively. One is the MDTs, these advice and guidance, etc. So many ways. One is go and do outreach clinics in the community. So what we did was we did a pilot. We did 3 clinics, 3 pediatricians. Some of them had nurse alongside, others didn't have nurse alongside. Some of them had GP, others GP wasn't available. Along with the clinic, we did teaching session. Now this was basically for GP education. That was one of the primary goals. But they were very successful in the sense that we collected feedback, brilliant feedback from patients, from GPs, and the education value was really appreciated. So that was another evolution, you can say, in the way of things. But we have the problem there was that I think we could not have a GP in the clinic because they couldn't provide funding, etc. So that, for the time being, that our clinics is not going on. It was a pilot, it was proven, but we are now, next bit, when I'm going, I'd rather do MDT and the teaching session rather than a full outreach clinics. They did, I think only 20% of those children needed to come back for a review to hospital for blood tests or a review. The rest were all discharged from the outreach clinic. Okay, while I'll keep talking. We did. Okay, so these are things which we've done. Other than that, with under the Better Care Together umbrella, we did an audit in the ED, emergency department, A&E, where we sat down, looked at all the referrals, everything coming in through the service, GP, pediatrician, ED consultant, ED nurse, and I think there was a pediatric nurse as well. So it was we looked at what we can, are they appropriate, are they not appropriate, what could be done, what could be alternatives. So, and we looked at summer patients and winter patients, both seasons we looked at, both hospitals, the sister hospitals. We found about 25% were avoidable. Coming to ED, these admissions were avoidable. one of the big findings was the 111 service. I think 90% came to A&E. So out of that, the audit, we got some points to work towards, which is giving more information. So you grab the patients who are there in ED, you take them and you give them more information about the illness and about the other places they can go to, for example, pharmacy or GP services, etc. Everybody doesn't need to come to the hospital. The other thing was we need to talk to 111 services. I think every child under 2 we saw were being rushed to the hospital. So we are going to have a discussion around that. So that was our audit with outcomes and points which we need to work towards. Then we did a similar audit with GP referrals. So I sat down with the GPs, see their referrals from their ICC, and it was roughly similar, about 20%. They could see and sort themselves or use advice and guidance and did not need to come to the hospital. Very well done, very well done. And okay. Okay, so I've discussed these. I've been through all of this, I guess. So, okay, I'm here. So this GP referral audit, sat down with GPs, had a look at things. 15 to 20% were avoidable. And they were going to take that to their own GP surgery and dissipate this information to their colleagues. Let's go back to the ED project. So 38% were inappropriate attendance. This is the patients coming to A&E. 111, 6 out of 7 cases were, they're all 111 is, you ring, you're a parent, you ring 111 and they'll either come, take you, or they'll say go to A&E. So that's another problem. 48% were discharged from A&E, 16% needed parent education. Then we got recommendations. Information leaflets for families we're putting out on screening, on TV screens, etc. It's very difficult to get hold of parents to tell them you could go to pharmacy, you could go this, there, and then. But it's not that difficult when they come with a problem and you say, listen, you could go there, this could have been sorted there. So we're trying to take that opportunity. We're trying to involve our integrated children's nursing team. This can be diverted to them. Videos in A&E, 111 service is going to talk about, and schooling is very important. So with this, we're going to talk to people in schools. They can give information, or they can give the information to children, or in the parent evenings, etc. Okay, so then community nurses were there, but their role has expanded in the last few years. It's evolved. We got community nurses, liaison nurses. They were previously, some of them were commissioned of Blackpool, and now they're in our trust, so we will know about that more. I think the commissioner has arrived. They're hands-on, linked to inpatient pediatric also. They will come every day to our ward and see whether any help is needed. They can help in any way. Mainly they look at complex needs children and community, and they form part of the MDTs which I discussed. Liaison nurses, they're more health visiting capacity, involved with safeguarding, and MDTs and other projects that I mentioned. We've done 3 newsletters so far for GPs. So these come out of, it's mainly GPs, but I advise on the letters. Usually seasonal pediatric problems, like you mentioned, the feeding difficulties or cow's milk protein intolerance, etc. Guidelines, videos by GPs, for GPs, how to manage, some videos done by our pediatric colleagues. And signposting to referral pathways, other useful information, and advice and guidance signposting. So somebody emails me, GP emails me saying, problem, what do I do? I say, do this, and this, and I put in a link for the newsletter. Have a look at that. Although it's on the CCG website, but I don't know how much people read or have time to read on CCG website. If you're got a problem, that's the time when you actually do reading. So I think that's an important time when I can signpost. We got advanced pediatric nurse practitioners, 4 of them. They have come along in the last 3 years, qualified now. 3 in pediatrics, 1 neonatal. Gaps on the rota were mentioned. They're brilliant with covering the gaps on the rota or sickness, etc. And their skills are improving. I think you got to give them a chance. As they work on the shop floor, their skills, you will find some can even work at registrar level. Okay, so we mentioned GP referral audit. Okay, so these are our, this just, when we were in better care together, these are key performance indicators. So the aim was to reduce outpatient referrals from GP, reduce follow-up outpatient appointments, reduce pediatric emergency bed days, and reduce inpatient pediatric admissions. These keep changing year on year, year off, but the whole point is to basically patients not to come to the hospital. That's one thing, sort out things in the community, and the other thing is give services all near the child. So they sort of get together, but the problems we've been having is commissioning again, where does the money come from, and having keen GPs who say to me, come, I'm here with you. It's just most of them feel overworked, and the keenness is difficult to generate, so to say. So, but so far from there, you can see there's so many projects that are still ongoing, and we are slowly making progress. Happy to answer any questions or have discussion around these. Because I've put in so many different projects and different things. And sorry about the
Imran.
My question's more about the GP clinics that you've been going out to do. With the lack of the engagement with some of the GPs, have it ended up that you've just been doing a general paediatric clinic that you would have done in the hospital in their GP surgery instead? In which case, I'm not surprised that everyone likes it, but has actually anyone gained, apart from the fact that you've had to drive to the GP practice and the patients just had to walk up the road? These are ones.
Sorry, I missed that slide because it died on me. So, there are some things to gain there. For patients, reduce distance, location convenience, revisit hospital wellness, value of learning time, 86%. Confirmed education from case discussions and formal teaching. So you're right, formal teaching was more precious than seeing patients. But when I was there, there was a GP who was with me. It was her case. So I think management she found useful for her own sake. Then after 2 or 3 patients, she had to leave because one of her patients has had a stroke, adult patient. GPs are very busy. They're out of this is what I found. So then there was a GP trainee with me who found it useful to be there. We've had this discussion previously with my colleagues. If we go out and do clinics, we want a GP to be there for the learning. When you talk to GPs, they say, we can't have that time because it's, where's the funding for that? You need to backfill it, that sort of a thing. So after this, we felt doing actual clinics, rather than we can just go and do MDTs and we can do the teaching bit.
Can I just ask about the rapid access clinics and how it actually works? Because we've sort of tried to do this and it's really struggled to keep it down to 24, 48 hours having a slot. They end up being a slot in 2 weeks, which sort of defeats the object of getting away from the assessment unit. You mentioned you did it by telephone. Are the because that's the other issue. We tried to get the GPs to phone us. We tried to have all day, and then we've had set times, but we struggled to get the phone conversations, and then ends up being full of patients who, to be honest, don't really need to be seen urgently, but dermatology don't have a rapid access seizure, so they'll send us a difficult rash and things like that. So just wondered how you'd managed to keep it down to 24, 48 hours.
So GP, these rapid access clinics are, again, some of my colleagues don't see much of a benefit in it. Some of them do. Some of them say, oh, they're urgent. Oh, this can be seen in a week. You ask 3 clinicians, one might say 2 days, 4 days, 6 days, la la la. What we did was, it's a phone, it's like a bleep. You get a bleep. I'm a consultant. I get a bleep. Okay, I have this child. I say, I don't need to see this today. Why don't you send an email to children's outpatients, do a referral, put rapid access clinic, put my name there, and that you've discussed with me, goes to the generic children outpatients email. They usually, that's manned, the email is manned. So till the end of the day, we got a very good outpatient administrative team. Till the end of the day, they keep next day appointment or the day after appointment. If that doesn't get filled, they fill it. That means ringing around parents, etc. But we have really great team. And if there's no appointment in the next 72 hours, comes back to, they ask us, listen, can't fill it, what do you want to do? Then we decide, okay, yes, no, maybe we need to come to CAU, etc. I don't know the time frame. I didn't do the audit on the time frame, how many. But what we did find was, because there was a question, is 1 a day enough? Or do you want more? But then we found that no, 1 a day was enough. And there have been times, it's a bit seasonal as well. There have been times where it goes empty. So you have to fill it. But again, I don't know how busy other district generals are. If it's a busier district general, maybe you need more than some of them do 2 clinics a week where you see 4 patients a day or something. So full on. This is, we get a slot in our regular clinic as a rapid access appointment.